Hello everyone, my name is Clare Enston, as you can tell. Core, I don't really know how to follow everything that's just happened, but try I will.
Give us a tune, Clare.
So that's Gillian from my team. Gillian's not the first person to suggest that I might sing right at this moment in time, because I do sing. But it's not going to happen, don't worry. But I do know how meaningful it would have been for them to kind of share what they do with you. And I'm going to give you an update on some friends and family test things, and also give you some insight, because that's my job. I don't want to take up too much time, but before I launch into that, I just going to take a moment while I've got the mic to just really to say how brilliant it is to celebrate you and your wonderful work, and how great it is that we get to do this every year, but just to pinch a few moments to celebrate the person behind me. Because it's come to our attention, Ruth, that you're very passionate about patient experience, to the degree that you've just been awarded an MBE. Thank you, and we can tell how much it means to you just by your reaction just there. So on behalf of, I think, probably me, everyone in the room, people from Penner Awards past and probably future, thank you ever so much and congratulations.
Thank you.
Now, really hard to follow that, so I'll crack on. How much time do I have?
20 minutes.
20 minutes-ish,
Just
okay.
under.
Okay. Super. So, to the business. So, you'll know that, I'm hoping you'll know that we've been doing some work on friends and family tests to see if we can improve it. I'm not going to spend too much time on this slide, just to say we know it's done some good stuff, but that's no reason to not see how we can improve it. We have done a big job of listening ever since it started. We have made changes where we can. So, for example, we removed the use of the Net Promoter Score as the set of results, pretty much straight away after 6 months. We stopped RAG rating the results. We removed response rate targets. We removed 3 of the 4 maternity response rates, for example. And we also published guidance about handling sensitive situations. So we've tried to be listening. And since April this last year, actually, we've kind of really done some concerted efforts in terms of listening to understand what could be improved. Recently, our director Neil wrote a blog, so there's the link in case you want to have a look at it. But really, I was going to highlight some of the things that we have learned in our endeavours over the past 8 or so months. There we go. So some of the key things we found. So it'd be interesting to check out your reactions to see whether these chime with you. So clearly the first thing is about the wording of the question. That doesn't seem to work very well. So the concerns there about that, and how I think possibly for patients, for people who are trying to answer the question, not understanding what it means, and is it appropriate that I'm being asked this at this point in time, and how does this relate to healthcare? And also for staff who are involved in the process, having to explain it continually, which is not a good use of your time either. So we think there's some gains to be made on changing the questions. People have also said that the question itself doesn't necessarily lead to the best quality written feedback in the free text. It doesn't elicit that sense of really for the person to convey what's happened to them and how their experience has been. So we think there's some room to look at that. We've been busy doing some testing, so we had a number of sites testing alternative questions with patients in real time instead of doing their default FFT question. Without fail, although they were testing alternative questions, a different range of them, the feedback was that staff had to spend less time explaining to patients what was really going on here. So across the board, that seems to have been an improvement. The interesting thing is that there's no overwhelming consensus for what is the better question. Everyone knows that it's currently not the best question, but no one has managed to galvanise collectively in a group what that single question is. So we took a short list and we've done some independent research to look at what would be the best question possible. And the last couple of points, we know that we've heard through these conversations that there's a tendency to still and try to understand a trust performance in comparison to other trusts. And that's I guess the human nature in us wanting to see where we are, keeping up with the Joneses, that kind of stuff. But it's really important that the FFT data is used in perhaps a more realistic way. We know it can't be used for comparison, so that's one of the messages we'll be reinforcing when we launch the new policy. And we also know that teams have sometimes felt compelled that they have to focus on the collection of it. And I understand why that is, that you've got some quite hefty guidance in existence that tells you this is how you should do it. And also you might have people having conversations with you about how many responses you're getting and has your response rate dipped and things like that. And what we would really love to get to is a place where the conversations are more about how are you using what you're hearing and what are you hearing, rather than pursuing a response rate when actually maybe you've got enough feedback already and the messages are coming through loud and clear. So that's some of the feedback we've had as well. So those are the main messages. Do they sound pretty solid? Yep, good. Okay, so we've put together a set of proposals, and in doing that we have built on the work that we did in 2014. So there was a review after it was kind of in place for about 6 months or so, which looked at, okay, so how is it working in earnest? Now it's operational. And the review really found that FFT has some strengths and we should make the most of those. So for example, it's different from your national surveys. It's not a sample, it's for everybody that wants to give feedback. So let's not exclude people in the process of doing this. And it works really well, best at supporting local service improvement work. It's about how you use it locally and about the messages you receive. We don't see the free text. That it's down to local teams to really interrogate what they're seeing and decide what to do as a result. So let's play on that. Let's keep going with that. Let's encourage people to use it to plug the gap. So where surveys are strong at comparative data, use them to understand how do I fit against my peers. Use FFT to get underneath the skin of that to find out what you could be doing and how you're making progress over time. Although our proposals haven't been agreed yet, and I would dearly love to be standing in front of you giving some announcements and saying this is what it looks like, I probably would get sacked if I did that, so I'm not going to do that. But to give you a flavour, we'll be building on the work of the 2014 review, which said the strengths are in its local application and that it's for everybody. So that's continuing in the same direction there. Just in terms of how you use it locally, I think there's a number of different ways, and some of the discussions this morning I've thought, I must mention that because that's relevant. So for example, carers, there was a really great presentation in the morning session here about carers and the work there. So if you're having a focus on carers and you want to find out what carers feel, you can use FFT to do that, absolutely. Put I am a carer box tick, or I am a relative, or I am the patient box. Make it work for you so you can understand whose voices you are hearing from. Use the free text questions to ask something specific to the work that you're doing, and that could be about carers, or maybe your inpatient scores point out that actually discharge needs a bit of work, for example, or maybe you've recently agreed some local always events that you're going to be doing, and you can use the FFT to see how are we doing against our always events. Are we actually doing what we said we would? So make it work for you, I think, would be my main message, and I'm hoping that the new guidance will only continue to strengthen that message. So I said we've been doing a lot of listening. Here's a bunch of people we've been listening to. I think the conversations we've had since April have been in the region of 1,300. Something like that. We've done our very best to reach everyone that wanted to have a conversation with us and be part of discussion forums or just phone calls or fill in questionnaires about it. So we did some questionnaires to look at what's the impact of this going to be. This isn't about a new policy, this is about changing something. So if we're going to change it, we need to be clear we're not going to make life difficult for you in the process and try to minimise that where we can. So that's the questionnaires to providers and commissioners and suppliers. And if you responded to those, thank you very much. We also set up a couple of working groups which have been with us throughout the whole process, and with them we've been refining our findings and getting their view on them and honing the work further. And we've done specific work for specific audiences, so speaking to the youth forum, the young people's forum, with midwives and midwifery staff, because we know that was a particular issue about the touch points in maternity settings and it's just not working so what should we do about that? Obviously we spoke to patients and the public. We've spoken several times to Health Watch, Complaints Managers Forum. You can read obviously, but that's the kind of the people we've spoken to. And then just to make sure we weren't making stuff up, we commissioned some independent research to see independently, what do people think, and what would be a better way forward. So you can see there the types of conversations they had with national stakeholders, but also with staff. So there was a number of online discussion groups with doctors, nurses, healthcare assistants to get their views about friends and family test. And of course, we cognitively tested our options in terms of new questions with people, just normal people, just to make sure that it was going to work well. So whilst can't make any announcements, we will find numerous ways to keep you up to date. So we have got dedicated web pages. So we've got the FFT web page, but there's also a development project web page. We'll publish new guidance. We will be writing out to chief executives of trusts and to commissioners and to primary care professional bodies. You can subscribe to our monthly update through that email address, england.insight-queries@nhs.net. I was trying to learn that on the train this morning because I thought I ought to, by this time, know what my email address is. And we have a friends and family help desk as well, who are available all the time to answer queries and questions. So if you want to know what's going on, please just get in touch, because we'll be more than happy to share what we can. And when it comes to knowing what we can say in terms of a finalised policy, Gillian has put together an extensive plan for comms and engagement, and it's been the case for the past couple of years. We've worked really closely with Louise and Ruth and Helen on a series of regional events to celebrate the winners from this event, but also see if we can help and support in any way. So it's my hope that when those come around in the spring, we will absolutely be able to be talking about the new policy and what it means, and have some time to talk about that. So yes, that's the news on FFT in as much as I can share right now. But I'm hopeful it's in the right direction, and it'll work better for everybody involved, is my hope. On to as important business now, and this has been mentioned several times today, the importance of children and listening to children and hearing from people who perhaps we don't hear from as regularly. And because I work in data, I thought I'd bring you some data, share the love. So there's we do the general practice patient survey, and I realise that not many people in the room will be working in the primary care setting, but I think it's interesting what we can learn from it in terms of its applicability elsewhere in the system, particularly as we start working beyond boundaries and across integrated care systems. So we have done a cut, our supplier has done a cut of the data looking at what does 16 to 24-year-olds think about primary care services. So this is based on the 2018 survey, and this particular question focuses on mental health needs, as you can see. So interestingly, young people are more likely to say than older patients that they had a mental health need at their last appointment. So they could have come in for anything, but actually it is a mental health need, and more likely to say that, and that's 45, so it's nearly half of younger people saying that that's the case. So in terms of what happens beyond primary care, I think that's really interesting. And also combined with the question beneath, less likely to feel that the healthcare professional they last saw recognised or understood their mental health care needs, less than older folks. So more prevalence, less being recognised. And thinking about the communication then, probably not surprising that young people are saying they're less likely to feel that the healthcare professional that they saw was good at listening to them than older patients. So could be in this worrying situation where we've got larger numbers of young people thinking, I need to go and see a GP for a mental health care condition, not feeling understood and not feeling listened to. And what does that mean for the rest of the system? How can we support primary care colleagues? How can we support each other actually in terms of understanding young people and what their needs might be? On a similar theme, thinking about long-term conditions. So young patients almost twice as likely to feel isolated from others compared with older patients, which is quite staggering. We don't, I think, probably expect that that would be the case. You're at school with your friends or at college or, in society at large, and yet feeling twice as isolated. And young patients with a long-term health condition were more likely to say that they don't feel confident to manage any issues arising from this condition. So nearly a quarter of younger people not feeling able to to manage, and more likely to say they need support from local services or organisations to help them manage. 3/4 of people with long-term conditions saying that. So there's just some food for thought, really. This is what young people are saying to us about primary care, and I'm sure it flows through to the rest of the system. Staying with young people, it's always important to remember this is data, and this is numbers of people. It's always to remember that the numbers are actual people at the end of the day, all individuals. So as well as we do this survey on a yearly basis, but last year we went out and did some kind of richer research with young people about their experience of primary care, just to get under the skin of it and speak to people. And these are some of the findings. This is going to be available online at some point soon. But really, and there was someone, I think it was Cornwall, earlier this morning, they were saying some of the stuff was surprising that they found when they spoke directly to patients. And I think that's possibly the same here. So feeling like their preferences aren't being met when it comes to having appointments. Really interesting thing around the role of parents, and I'm not for a second saying that parents ought not to be involved, but there was really interesting thoughts around in those early teenage years. They were keen to try to have conversations without their parents in the room. There were thoughts around, well, maybe my mum gets it wrong, but I don't feel bold enough to tell her that she's got it wrong in front of the GP because she's an adult, and so she must be right, but I feel like I can't challenge that. And so giving the opportunity for young people to have the consultation by themselves, the message was that would be welcomed. Actually, give me a choice about whether I want my parents in the room or not. If I do, I'll say, but actually sometimes it would be quite nice to have that time with the doctor myself so I can speak more openly. In practical things about the visit, I think that's been echoed in some of the other stuff. People don't know what they're coming to, which echoes the Walsall app. How do I know what I'm coming to? Where's the waiting room? If someone were to show me to the consultation room, I would feel more confident about what's about to happen. And some really interesting things around how are people speaking to me? So there might be really good, strong policy evidenced reasons for asking about sexual health early on in teenage years, but it's really embarrassing. And they really don't like it. It's particularly girls, young girls, and they're being asked straight up questions, So just thinking about the ways that we're speaking to younger people. We're not the only people doing this, and I need to update this slide pack today because Cornwall have clearly been doing some of the things and have got a fab video. But the other one I was aware of was the Edge Hill video, which was about coming to hospital and having procedures and some learnings that they found. So we're, I think, going to be doing quite a bit of work on children. We've done some of the primary care work, as I mentioned. There's some cancer work I'll mention in a moment, but also mental health. And we'll be seeing how can we pull of our learning together in a way which supports people in the wider system. So if you have any examples of how you've listened to young children and young adults, please do let us know, because we would be really interested to see what you've come up with. And I'll be adding the Royal Cornwall thing to the evidence base, absolutely. So just to touch on cancer. So we, and the brilliant Kath Evans, obviously, went to the Click Sargent residential to speak to some children to find out, what's it like to have cancer when you're young. And these were just some of the kind of graphic images that came out of that. So again, you'll see there's stuff about food, interesting stuff around, when you go through treatment, your taste buds change and your sense of smell changes. So actually the food needs to be different for me, because otherwise it's just not working. It's not good enough. But also some things, talking about surprising things, really insightful stuff around, well, it's cooked right in the kitchen and then it cooks too much in the heaters on the way to the ward. So how can the actual processes be adjusted? And another key thing that came out of this, you'll see the word sisters and brothers there. Siblings are a massive part of this for them. So getting it right for the whole family was a key message that came through. So that's broadly it. Really, I think I was just trying to think, how do I follow singing, which is pretty staggering, and just the joy. We saw the joy. It was terrific, and the joy in listening to it, but also the joy in being heard. And I hope that our endeavours in terms of listening to patients and listening to staff, particularly in terms of developing the Friends and Family Test, you'll feel that we have listened when the policy comes out. You'll have to tell us when it is published. In terms of children, though, one of the other messages that they said, I think Kath asked, what one message would you give to the NHS? What would you like them to know? And this is what Poppy said, which was just a massive thank you. So I'll echo Poppy and say thank you very much for having us again, and thanks for listening.